Okay, get this. We're talking about catheter-associated urinary tract infections, CAUTIs today. Super common in hospitals, right?
No, absolutely. One of the most frequent healthcare-associated infections.
But here's the kicker. Up to 70%, maybe even more, are thought to be preventable. 70.
That's a huge number. It really highlights the opportunity for improvement.
Exactly. So today we're going to dig into this really impressive 6-year study from NYU Langone Hospital on Long Island. Our mission is basically to unpack how they managed to slash these CIUTI rates so dramatically and, what that means for patients and hospitals everywhere.
Right, and it's critical because these COUTIs, they aren't just minor issues. They can be really serious. We're talking sepsis, which is your
Mm.
body's overwhelming response to infection, potentially life-threatening, and bacteremia, a bacteria getting into the bloodstream. Plus, it fuels antibiotic
How
resistance.
does it do that? The resistance part.
Well, often bacteria on catheters form these things called biofilms. They're like sticky protective shields. Makes it really hard for antibiotics to work. And beyond infections, there's other harm too, like falls, delirium, even bleeding risks.
Wow. So it's not just the infection itself.
Not at all. And there's a big financial angle too. Back in 2008, Medicare basically said, we're not paying extra if a patient gets a CIUTI in the hospital because, they're often preventable. So hospitals have a very strong incentive financially and ethically to reduce them.
That makes sense. A huge push factor.
Yeah.
So NYU Langone, what was their game plan over these 6 years?
They launched this really comprehensive quality improvement initiative, a QI project. It ran from 2017 all the way to 2022. And the key thing was, it wasn't a one-shot deal. They used the Plan, Do, Study, Act model, PDSA.
Ah, PDSA. So like continuous cycles.
Exactly. Plan an intervention, try it out, study the results, and then act on what you learned. Adjust, refine, repeat. That constant learning and adjusting over 6 years was, I think, fundamental to their success.
That sounds really thorough. So what kind of specific things did they actually do? What were the interventions?
It was definitely a multi-pronged attack. They focused on three main buckets, basically. First, reducing catheter use overall, making sure there was a really good reason, a proper indication before putting one in. They even brought in non-invasive options like external collection systems.
So step one, just use fewer catheters if possible.
Yeah.
Makes sense. What else?
Step two, improving the care when a catheter was necessary. Think daily checks, proper maintenance, clear documentation. They used specific post-insertion cleaning wipes, had educational videos for staff.
Little details that add up.
Precisely. And ensuring any system that was compromised, like if the seal broke, was replaced immediately. They even talked about catheters and daily safety huddles.
Okay, so avoid them if you can, take meticulous care if you can't. What was the third area?
The third was changes in testing. This is interesting. They wanted to make sure they were only diagnosing and treating real infections. So, for example, nursing assistants weren't allowed to collect the urine samples from the catheters anymore to ensure proper technique. And crucially, they set up rules so that a basic urinalysis test would only trigger a full urine culture if specific criteria were met.
Ah, avoiding unnecessary cultures based on just, say, cloudy urine without other signs.
Exactly. Preventing overdiagnosis and unnecessary antibiotic use.
Okay, so reduce use, improve care, smarten up the testing. And the results after 6 years of this sustained effort.
They were honestly pretty staggering. They saw an 80.6% reduction in the CAUTI rate per 1,000 catheter days.
80.6%.
Yep. It dropped from nearly 2 per 1,000 days down to about 0.38.
Wow.
And get this, if you look at it per 1,000 patient days, which accounts for fewer catheters being used overall, the reduction was even bigger, 89.9%.
Almost 90%. That's incredible.
It really is. And alongside that, they managed a 48.1% decrease in how often catheters were used in the first place, the utilization ratio.
So nearly halve catheter use and dramatically cut infections when they were used.
That's the key takeaway, I think. It wasn't just about using fewer catheters, although that helped significantly. It really shows the power of improving the entire system, the care processes, the testing protocols, that persistent, multifaceted approach, constantly refined with those PDSA cycles. That's what made the difference. It shows you can tackle these really complex, ingrained problems.
It's such a powerful story, a real testament to sticking with quality improvement.
Absolutely.
So the big message here seems to be that these focused, iterative, long-term QI efforts can genuinely move the needle on major patient safety issues.
Definitely. It proves that significant, measurable improvements are possible, even for widespread problems like CIUIs.
It makes you think, doesn't it?
It really
Mhm.
does.
Yeah.
And it leads to a broader question, maybe for you listening. Considering these results, what other tricky problems, maybe in healthcare, maybe somewhere else entirely in your work or life, could benefit from that same kind of systematic, persistent quality improvement mindset? Where else could that iterative approach make a real difference?